Good morning. We're ready to start. My name's Debbie Yang. I work in the Infusion Center at St. Joe's, and I have the honors of introducing Wendy Baer. Dr. Wendy Baer helps patients and their families deal with the stress of receiving a cancer diagnosis and subsequent treatment. As a psychiatrist, she has expertise in treating clinical depression and anxiety, both with medications and psychotherapy, to help people manage emotions, behaviors, and relationships. The fundamental goal of Dr. Baer's practice is to promote wellness and maximize patients' quality of life as much as possible. Please welcome Wendy Baer.
Thank you guys for inviting me to come, for coming and joining me in this room. It is a delight for me to be here with nurses, although I'm a little nervous, I must admit. I recognize some faces. I imagine that some of you have seen patients that I've seen, and now I feel like we're kind of like going behind the curtain a little bit, like you've read the note, and now here I am live. And so I hope that we can find some common ground and I can say some things that are helpful to you, not only in the work that you do in taking care of patients and families who are dealing with cancer, but also in terms of your own care. And when the organizers asked me to speak, my impression was that what they wanted me to maybe focus on was what we do to take care of our own mental health, not only the mental health needs of our patients. Of course, these things are going to overlap, and I'll speak to that as we go through the talk. This talk is being recorded, so if you have a question or a comment, we'll ask you to come up to the microphone and ask the question so that the people in the audience can hear later on. And I need to stay behind the microphone because of the recording, so my tendency is to kind of wiggle a little bit, and it's only because I have to stand still that I am wiggling. The other thing, obviously, is if you have a conversation, just keep in mind it's being recorded. So sometimes I get caught with that. Okay, supporting our mental health in the oncology nursing environment. As with the introduction, I am a psychiatrist. I'm not an oncologist. I'm not trained as a nurse or an APP. I'm trained to take care of people with mental health issues or mental illness. But I've been working in the cancer world for a number of years. Before coming to Atlanta, I was at the Swedish Cancer Institute in Seattle. And then I came to Emory, and in 2011 took on the job that's sometimes called supportive care, sometimes called psychiatric oncology or psycho-oncology, behavioral health oncology. But it's a role that many of the tertiary care specialty designated cancer centers have for patients, whether it be a psychologist or a psychiatrist. And we work alongside the other supportive care professionals, social work, nutrition, some of the other physician specialties like physical medicine and rehab, palliative care, anesthesia. So I don't have any financial disclosures. I told you my disclosure about being a psychiatrist. I'm quite partial to Emory and quite partial to Winship. And I know there are many excellent medical centers across the country and the world, but this is my team, and I'm super proud of the team that's putting on this conference. Supportive care was what I was speaking of. It's kind of this umbrella term that's used for sort of all that is cancer care, in addition to chemo, radiation, and surgery, being like those three central kind of pillars of interventions that we're using for cancer care. These are my professional organizations, which can sometimes be very helpful to other cancer care professionals. The American Psycho-Oncology Society is a national organization with primarily social workers, but some psychiatrists and psychologists. They have a meeting in March in Pittsburgh. And the Academy of Consult Liaison Psychiatry. So there are other psychiatrists that work in medical surgical settings with specialty in cardiology or endocrinology, diabetes, in solid organ transplant. I happen to be in cancer care. So nurses are people too, right? Duh. But sometimes we got to state the obvious. We do a lot of talk about what to do for our patients, and it's a little bit like the person you're looking at in the mirror is the one we need to think about how are we taking care of. We are talking about taking care of ourselves in a professional setting, which is a little different than what you might think of in terms of what you would do with your own psychotherapy or your own personal medical care that you had with your own psychiatrist or psychologist. And maybe that's also a little different too than what would be happening as you work on your relationships at home and with friends. And so as I think we think about our mental health and how we regulate our emotions and behaviors with others, it's very important to look at the setting. I'm going to try and use language here that's matching for this professional setting. You might hear other words from me at home if I was not being recorded with my kids, or maybe if I was trying to play a sport or, out in a casual environment with old friends. Wellness is sort of its own world, in addition to mental health. In psychiatry, we spend a lot of time on serious problems with brain function. In wellness, we spend a lot of time thinking about how to enhance being functional as possible. Burnout is the consequence of not attending to wellness, and I was really pleased to see one of the pharma reps out there had a how to navigate burnout, and we will talk about burnout as we go through this talk and try to distinguish that from mental illness. And then, of course, systemic issues, the environment that we're in. We talk about our mental health for the people we're working with, but we also need to think about the structure around us doing the work that we're here to do. Okay, we all have sort of like a personal role to play. I've just mentioned structural issues, which we will talk about, but all these sort of basics, which are almost so elementary, like we know we should pick the apple at the breakfast bar, but I got the blueberry muffin, like we know these things, like maybe I need 1 cup of coffee and not 2. But it's a fascinating phenomenon to think about what drives behavior. What are you motivated to actually do? What do you care enough about to actually choose? And then we think about the physical and the mental, and sometimes they get separated. Our healthcare system is terrible for separating them. Often the mental health carve out for insurance, the mental health carve out for place that you go versus the place you go to see your primary care doctor or the place you go to see other specialists. Enough symptom to control to function. So what do I mean by that? So in my work with patients, we're talking a lot about symptom control, usually fatigue, sometimes nausea, sometimes focus or concentration. And we want to get those things like packaged up enough so people can take care of their families, go to work, get into their next appointment to function. And then one next step beyond that is we start to think about, well, can I do more than function? Can I actually think about thriving? So as a psychiatrist, I can't be here without providing a little education around mental illness. And sometimes it comes with so much stigma, right? If you've had a mental illness or you have a friend or family member with a mental illness, there's a little bit of, that comes along with that. Because the brain is still kind of mysterious. We understand other organ systems in a different way than we understand the brain. But if we can say it as the emotional or behavioral symptoms that interfere with your ability to function, it seems pretty straightforward, right? Well, as long as we can identify those emotions, which is sometimes hard for people to do, or check out the behaviors that we're engaged in that are worsening things. Serious mental illness is what the bulk of psychiatry is about. And SMI is schizophrenia, bipolar affective disorder, which happen to have several types. 1, 2, and then a cluster of not otherwise specified, and major depressive disorder, major depression, which is different than being sad. And we'll talk about that a bit. When you're doing your clinical work, or when you're thinking about yourself or a family member, sometimes it's helpful to put symptoms into domains. And we can imagine I had an elderly patient yesterday above 70 who came to see me for anxiety, but really the domain, once you do the interview and start getting some more information that she was struggling in, was in her thinking and memory. And she presented as anxious, but actually she was having symptoms that may meet criteria for a neurocognitive disorder like dementia. Mood and anxiety we're very familiar with given the stress of cancer diagnosis and treatment. Substance use, we probably should be more familiar with, given the risk factors for cancer are very much tied up in substance use. And whether we talk about alcohol or tobacco, other drugs, whether we talk about food, and there's a lot of debate about food as addiction and obesity as a cancer risk factor, that we can have lots to say in that domain as well. We don't see psychotic symptoms nearly as often in psychiatric oncology as in other parts of psychiatry. We certainly hear it used in popular press and in shows and in humor that sometimes shows up on T-shirts or on coffee mugs. But when people are psychotic, when they have a break from reality, they're not with us in this reality because of what they hear or what they think or what they see. It's exquisitely painful. And then a huge domain of issue that interferes in us getting along with patients and families and us getting along with each other can be around personality and relationship stress. I mean, you can imagine, I mentioned something about words I choose at home. I have a horrible night at home or a horrible morning at home, and I show up here and I'm like, just try to forget about it. Just try to forget about it. Just try to forget about it. But it's part of who you are, right? So if you have serious relationship tension at home, it's likely to pop up through your day if it's not addressed. The DSM, Diagnostic and Statistical Manual. So this is psychiatrist's guidebook, rule book, list of criteria to meet a diagnosis. Do we have a scan or a blood test or a perfect picture to tell you which one you have? No. Can this get us into trouble with labels that come with a lot of stigma and distress? Yes. It's what we got right now. We're evolving. We included PTSD. We took out some of the very derogatory language around homosexuality. We're evolving, but it's what we have right now. Mental illness is extremely common for all people, patients, families, healthcare professionals. 1 in 5 adults living with a mental illness. SMI, serious mental illness, affecting about 5% of the population. And, knowing that in healthcare, anything 1 and above is a big number, right? That sometimes in other segments of the world, people won't understand that to be a big number, but that's a pretty big number with devastating consequences for caregivers, for families, and for productivity. So if you're living with a serious mental illness, your ability to engage and be functional at work is limited. Anxieties are the most common. Social phobia, social anxiety disorder ends up being one of our more common phenomena. And you can imagine what it was like, the first day of high school, the first day of junior high school. You got, nervous stomach, your thoughts are racing, who's looking at you, who's judging your sneakers, who's talking about your backpack, where are you going to sit at lunch, who's going to sit with you at lunch. And then that balloons into an adult condition where you're sort of paralyzed from going out and being in front of people. So, very common. Substance use disorders are right up there, pretty common, and then 6% for major depressive episodes. PTSD is kind of interesting, post-traumatic stress disorder. For most of our diagnoses in psychiatry, when you have a major medical problem, whether it be coronary artery disease or a cancer diagnosis, you're at higher risk for a mental illness. But actually with PTSD, it's about similar. It can be kind of similar, and it's kind of surprising, right? Criteria for PTSD means that you perceive the event as life-threatening. So you can have a stage 1 or 2 breast cancer and other medical problems that's very treatable, that's probably going to become a chronic condition, and perceive it as life-threatening and still get diagnosed with PTSD. It's all about how you think about what's happening to you. Okay, that's what I just said. So it's more common in the cancer population to have like a major depressive episode, anxiety disorders. As I said, the PTSD being about same as the general population. Agoraphobia, which is making me laugh right now thinking about trying to escape from this room, which I'm sure is up to code and fire safety and all, but agoraphobia is a fear of not being able to get out of your situation. So it's not necessarily claustrophobia, but it's I can't be out there because I don't know how I will get to safety. I can't be in the movie theater or at the ballpark. Substance use disorders, alcohol, tobacco. Turns out people still smoke cigarettes. It sort of shocks me sometimes. I saw a cigarette butt walking in today. But, I mean, it's still out there. Adult choices, but with health consequences. And, of course, the new phenomena that we even, don't even have our hands around how to understand and manage is the vaping of nicotine and what health consequences we're going to have, especially for young people who are starting so early. Opiate use disorder. So in cancer care, we're more familiar with opiates. We, see a prescription maybe for pain medicine. We're like, okay, this is part of treatment planning. In psychiatry, we see prescription for opiates, and we're very concerned because we've been addressing the opiate use epidemic and overdose deaths, and it has been catastrophic in the addiction world and for our population in the country. I screen people for caffeine on every visit. I don't know if y'all do with your patients, but it is fascinating. It's one of my more interesting moments in a clinical encounter. So do you drink soda? Yeah. What kind? Mountain Dew. How many? 8 or 9? 8 or 9? Like 12 ounces? Like I would be in the bathroom all day. But it is, once we start to look at the habit and ask the question, I'll sometimes say, what does your recycling bin look like? And, so it's of issue, especially in our management world, especially for people who work long shifts or maybe have less time to protect sleep, who maybe are trying to get through a long shift and doing what they can for their energy boost and then having trouble sleeping because their brain won't slow down. And then you're thinking, well, how can I get my brain to slow down? And all of a sudden we've got Ambien and Lunesta and Klonopin. And it's like, okay, wait, which direction are we going? When do we need to cut off the caffeine so I can actually sleep, right? Without having to use the sedatives. And then THC is the, technical name for the psychoactive component of cannabis. And we're having more cannabis use in the country than we've had as, recreational and medical use has expanded across the country and some consequences related to that. That's a whole nother talk, which I'm happy to try to address from a psychiatrist perspective if people are interested later. Personality traits. So this is what gets in the way in clinic usually. The cluster A that we used to call our people who have schizoid and schizotypal and antisocial, they usually don't come into clinic. They can't be around all the people and have the interactions. Or if they come in, they've got a huge tumor by that point because they've really delayed care. But people who have borderline narcissistic and histrionic traits, so emotional ability, self-attention focused, and histrionic, lots of drama, big feathers in the hair, lots of makeup, lots of entourage. These are the people that actually end up taking a little bit more time to manage because they've got so much else going on in how they organize their own internal world and their relationships with others. And then the longest name of one of our diagnoses that probably is the most relevant, psychological factors affecting other medical condition. That's a mouthful, and that's in the DSM. But the example I always give is one, you imagine you break your arm. And so somebody comes in with this leg fracture and radius and ulna, and they're getting it casted, and you get the history of what happened. So one person breaks their arm. They've been at home. They got in a fight with their partner or spouse, and they threw her against the wall, and she broke her arm, in a domestic violence event. Versus another person was out there playing tennis, reached for the winning shot, happened to stumble, fell, broke her arm, but won the point and, is really fired up to get PT and go back to playing tennis. And what are going to be the psychological factors of those two different situations, right? Or as you go into PT, or you go into trying to enhance, your range of motion or get off your pain pills afterwards. How are those psychological factors that are a consequence of those situations going to be affecting this person's future? So pain comes up all the time, and I mentioned opiate use disorder is one of our primary symptoms, although second to fatigue. So if you look at NCCN supportive care guidelines, fatigue is most common, pain comes in second, but lots of people experiencing pain along their cancer journey, and it gets in the way of people's desire to work towards treatment, desire to engage in treatment, and gets in the way of how we think and how we feel, all these things. But what you may not appreciate is how valuable cognitive behavioral therapy and physical therapy are for pain, way beyond what we can do with our medications, especially when we're dealing with chronic pain. So we really want to start shifting our focus away from our prescription pads and to our other interventions to manage chronic pain so that people can cope and feel like they have some self-control, self-efficacy, and improve their quality of life. So psychoeducation, I mean, we've essentially been doing psychoeducation just with this talk this morning. Like, how do we think about mental health? How do we think about mental illness? How common is it? What are some of the contributors? What are some of the factors? And sometimes I feel like in my practice, psychoeducation is sending people to websites. And I say, I'm not just trying to send you to websites, but I am trying to help you take on an understanding of what it looks like to be mentally healthy and what are things we can do. What are things we can do to keep people safe with the 5 domains here that was put out by a previous political administration, and maybe going to learn about anxiety or maybe learning about PTSD, most of which data-wise, literature-wise, comes out of the Veteran Affairs healthcare entity, but it's relevant for everybody. Okay, safety first. If you don't know, now you do. The new 911 for a mental health crisis is 988, and it's not so new anymore, but sometimes I feel like it hasn't really been, getting the attention maybe it deserves. The crisis line in Georgia is also the referral line, and most states have a crisis and referral line for mental health, so we call it GCAL, and these are people that are staffing lines and can direct folks, especially that are under or uninsured, to mental health care. Safety, we talk about guns, and I do this. I'm not taking your guns, but firearms are the most common way people die by suicide. And what we know is that it only takes a second to make a different decision. We just need a second. So those, little plastic locks that look like a 7-year-old could get through them, which they can, which is why they should be locked away from the 7-year-olds. But the little plastic locks give gun owners a chance to say, wait a second, is there another way? Can I give this a minute? Is there somebody I could talk to before I try to kill myself, something that's irreversible? Like, I just need a second to make another thought to pop into my head, donut. And the next thing you know, we maybe have a different outcome from that impulsive moment where somebody thinks they can't hold on anymore. Our medications are a big problem. People's medicine cabinets are too full. Their bathroom drawers are too full. Part of what we do should be to try to help people streamline and clear out their medicine cabinets. Knives can be a problem. It's not as much day-to-day a problem in my practice, although self-harming behaviors are another talk, not only suicide deaths, but, people who cut to relieve stress, which is kind of like a little bit of a grounding exercise, getting out of your head and feeling the pain on your skin. You ease psychic pain with somatic pain. Another talk. And keys. What do I mean by keys? Driving. Driving while you're using a bunch of medications, driving while you're using substances, driving while you're upset, driving while you're super tired. We're thinking about how to keep people safe. And then when I do evaluations for like medical, psychiatric safety, especially people leaving the hospital, it's always 3 F's and 2 M's: food, fire, falls, medications, and medical follow-up. Can that person talk through, how they're going to get something to eat? Who do they call when there's a fire? What do they do if they fall down? What medicines are you on? Like most of them, big ones. And do you need any medical follow-up? You're leaving with a drain. Do you need any medical follow-up? No. Oh, okay. Well, maybe we're going to have to get you some help while you leave this drain. I talked about driving. Safety first with finances. These are for people that are really struggling from a cognitive domain problem, whether they have dementia or delirium. They're really struggling and they need some help not losing all their money, not getting all their money stolen. We have to be careful with this because then they'll just think you're trying to steal their money too. Okay, I talked about medication safety, and what I listed here, and I hope you guys get these slides, with these websites are places where you can dispose of medication safely. And sometimes people feel really good about it. Like they've done their altruistic kind of recycling effort to dispose of medications. And I talked a little bit about how in psychiatry we're so serious about the opiate epidemic and treatment. So MOUD, medications for opiate use disorder. It is a treatable medical problem, and we have medicines to help treat it so people can function. Psychotropic medicines. So this is for patients and families. This is for us. This is for public health information. If you have a diagnosis where there's data to support use, not because you're sad because your family failed you on your birthday, not because you're mad because you have to work another Saturday and you were only supposed to work on Thursdays, but a diagnosis of clinical depression, SSRIs and SNRIs can be effective. They beat placebo by 20 to 30%. Are they perfect? No. Do they come with side effects? For some, yes. Headache and upset stomach. Sexual side effects? Yes, possible. 30% of people is what the data tells us. Some people with more problems than others. Sex is complicated. There are other contributors. We need to take a history. We need to think about this fully. In cancer care, the most common ones that I'm using, because we have a number of choices, escitalopram, Lexapro, pretty well tolerated, few medication interactions, but you need every day, several weeks of the right dose to get a benefit. Duloxetine, Cymbalta, pain benefit, neuropathy, chronic pain, muscle ache, somebody who has fibromyalgia, somebody who has lung, neuropathy from chemo, like this might be what you think of, duloxetine, Cymbalta. Many sedatives are used in psychiatric oncology, and many sedatives are used out in the general practice. Sleep, anxiety, claustrophobia, nausea benefit for something like lorazepam, but again, trying to be really careful, controlled substance along with opiates, perpetuating the crisis of overdose deaths. And then a number of people in my practice will take methylphenidate. If you have a diagnosis, like do you have a properly done workup to get ADHD, or maybe a properly done workup that looks at cognitive problems from chemo brain, and you are working and you are trying to keep it on track. You are trying to stay employed, and it is not happening despite your best efforts with exercise, sleep, nutrition. Could we consider adding a stimulant? Well, you're going to have to, think about what are you doing with your other sedatives. You're going to have to make sure that it fits with your other medications, but this is something that comes up in my practice too. Streamlining may be the treatment, especially in survivorship. I can't tell you how many people get off their sedatives and they don't need anything else. The treatment is stopping things. The treatment is not adding things. Talk therapy. Whew, this is a big one. Like, first of all, what do we mean? You should talk to someone. There's actually a book. You should talk to someone. There's all books. I'm stuck in that section of any bookstore is the self-help and positive psychology. But talking therapy, to me, that means you go weekly for 50 minutes for 12 weeks to get a full course of cognitive behavioral therapy. So that's like 3 or 4 months, right? Every week, 50 minutes, you and the therapist doing the work. And who could that therapist be? A licensed practicing counselor, a licensed clinical social worker, marital and family therapist, a psychologist or a psychiatrist. There's all kinds. There's all kinds of talk therapy too. So I just described a course of CBT, which is what insurance will pay for because there is data that says it works. So for psychotherapies, insurers want to know that you're actually doing something helpful and not kind of having like a rebirthing experience through some pillows and kind of almost suffocating on your way through some made-up birth canal. I mean, these are things that are out there. They want to know that you're doing something that is got some evidence behind it. There are many kinds of psychotherapy that my colleagues feel extremely strongly about and come with their own set of evidence that may not be covered by insurance. Psychodynamic therapy is more relationship-based. We think of the energy between people. Somebody comes home from work, they're in a bad mood, they kind of scowl at you, and then all of a sudden you're like, what happened to Friday night, right? Or people come in here and every once in a while they chuckle at what you're saying. You're like, oh, okay, I can keep going now. there's an energy that goes back and forth between people. And so psychodynamic therapy is about figuring that energy, especially with the point people in your lives, the ones that really can push your buttons, like your mom or your dad or your big kids, whatever it may be. Psychoanalytic is the Freudian model where you free associate. You're probably going every day, like 5 days a week for an hour for several years. It's a really in-depth endeavor. You have to be kind of well enough to do it and obviously financially able to do that kind of work. And then behavior activation, which is kind of my favorite, which is sort of in cancer survivorship. You get involved with Live Strong, you get involved with the YMCA, you get involved with the breast cancer survivors who are doing the dragon boat races on Lanier, you find a place, you find some people, you find a thing, and you go. Behavior activation is probably what's most needed for high-functioning professionals who need to take care of themselves, right? How do I need to coach up to get up and get going every day? How do I need to coach up to make sure that I have a proper dinner and a proper bedtime? How can we make this happen? Behavior activation, and the emotions come along with that. Healthy emotions, I hope. Insurance coverage versus private pay I spoke to. Our best resource right now is Psychology Today. It's really hard to find a therapist that's a match, that you can pay for, that's close to you, that you kind of, jive with. It's just got to be a match. And Psychology Today, the website, lets you use a bunch of filters for location and gender, shows some pictures. It's a decent resource. Okay. You know this. We all know this, right? I sometimes feel like I'll listen to wellness coaches or inspirational speakers or TED Talks or get another self-help book, and it's all packaging the same stuff in a new way. So your job is to find the person that resonates with you. It used to be like Richard Simmons would get everybody doing their jumping jacks. If that resonates with you, great, go do that. But it's got to be somebody that resonates with you. And especially with this kind of exercise situation, some people hate that word, exercise. So sometimes I'll call it safe movement. And some people be like, okay, they'll dance, or okay, they'll stretch, or okay. Some people do aerial arts, whatever it is, we got to move our bodies more. Okay. I mentioned earlier systemic issues. I am not in control of anybody's schedule, and I am not currently, in the room where it happens, where we figure out how many patients per person, when you start, when you go home. But I think it's been well described in many places, especially in pockets around the country, how we're dealing with shortages. I think our physicians will say there's shortages, certainly in mental health care, and definitely for you guys in the workplace dealing with the nurses' shortages. So part of crisis management is acknowledging the crisis. Part of dealing with difficult situations is acknowledging that difficulty is there. And so I'm calling it what it is. I get that part. And I think an opportunity we have, of course, is around expectations, volume, hours, but certainly scheduling. Because a minute ago, I talked about this daily activity schedule. I didn't talk about it. Maybe you saw it on the board. It's written out. We only have 24 hours, y'all. All of us. Same pot. We got the same pot of hours in a day. And so what we talk about is, how can I schedule this to make it work for me? And I say lunch anyone, because it's basically my answer to any wellness problem is, did you schedule a lunch meeting? Did you provide lunch? Do you have lunch off? Can you step outside at lunch? Lunch is to me like this golden thing. Now, maybe you work nights and your lunch is at 3 a.m., but whatever, lunch is some kind of golden time that we have opportunity to do something different, to connect with each other, to connect with ourselves, to reset for the rest of the day. I know about the administrative burden. Epic is solving it all. But like you said, we got to figure out how to use it, right? We got to use it the best way possible. And then obviously calling it what it is, the pandemic aftermath. We're still in it. Our young people are definitely still in it. And if you have young people who had developmental interruption through the pandemic with school, with learning, with jobs, with economic development, and they're in your family, you're still in it. So we're still figuring things out post-pandemic. I think that the political tensions are obviously playing out for us and for our patients. And the political tensions nowadays involve medical care. So it's not as if you can say, okay, I'm not going to go there because, yeah, it actually is affecting medical care, and maybe some ways figuring out how to advocate for our own health helps inform how we move ahead with our political activity. And civility. So this kind of goes into diversity, equity, inclusion, kind of overlaps with wellness. I'm not an English professor, so pardon language, but words really matter. And I want to be very careful to note that what we are looking for is for all of us to treat each other kindly. And that is, so central to getting good work done. Whether we're being kind with the unit clerk, whether we're being kind with the valet. I mean, I have a view of the valet parking situation on Upper Gate right off Clifton, and that is hard work right there. And both the valet workers as well as the patients and families are coming in. It is like tension central. And if we can find some kindness in our interaction before we even get in the building, it sets a different tone for us. I'm not saying that everybody's going to be nice to you, but you're going to feel better if you can find some civility in your day-to-day interactions. And I know at least at Emory, especially in our School of Medicine, our efforts around DEI are not political so very much as they're around people, because I know the woman that's in charge and she's about people. She's about people being good to people. All right. Financial tensions. Yeah, I kind of spoke to that with the pandemic aftermath. So we have a wellness program in hematology, medical oncology. About 5 years ago, Sagar Lonial, who's the chair of HMO, asked Caroline Peacock and I, and then we included Jennifer Mascaro, to develop a program to try and work with his department to reduce burnout and promote wellness. And so we had these features of our program, including a podcast series, which you can see online, and a little bit of a feedback modality. So I go to leadership meetings with HMO and listen in. And then just like yesterday, I sent an email with some feedback from a wellness perspective. Caroline Peacock is a doctor of divinity who is trained in a program called Compassionately Centered Spiritual Health, which is bolded there, CCSH. And this is a specialty program out of Emory University in the Center for Compassion Studies. And they do this with teams to try and help people understand each other better. It's a beautifully scripted group therapy that gets people to see each other as other humans and maybe treat each other differently because you know a little bit about somebody on a personal level. We try to support fun. Years ago, which I'll always remember because it was nurse-led, Roberta got people to do double dutch out in the garden. It was fabulous. I don't know why we don't do it every year, but we got clearance to do jump rope in the garden. And then we have a little gift program that we do for special pockets of people to try and raise their spirits. Wellness in medicine has been a national effort and an international effort too. The American Medical Association has a whole program on addressing wellness in medicine. There's an international coalition with British and Australian medical groups. The poobah, the grandfather of it all, I'm sure he wouldn't like being called grandfather, I guess, Dr. Tate Shanafelt was originally at Mayo and then went to Stanford, and from there sprung up Wellness in Medicine out of Stanford, and this is their professional fulfillment circle, which if you go to listen to any wellness talk, you'll see. They train people up. You can go there for 2 weeks, and you get super trained up in medical wellness programming. So there's literature. We do different things in different places depending on the culture of the place. There's a lot of talk about helping healthcare professionals be well so that patients are safe. Although it's interesting how long we've been using that. Sometimes leaders will be like, okay, enough. You can't make me buy lunches so that patients are safe. That sometimes we have to change the way we're presenting things because people have heard it many times, even though obviously leaders want patients to be safe. But what they will listen to is the return on investment. If you can show that some of your programming helps retain healthcare professionals, that is very meaningful to leadership because it is very expensive to bring in new people and train them up. And so what we really need to be thinking about on a regular basis is how to retain the people we have. I mean, the good people we have, obviously. Okay. National attention to wellness. I spoke at the National Academy of Medicine and AMA, and here's some of their infographics with various contributors. And on their website, they have all these toolkits about how you may bring wellness to your team. And the nurses do too. So I spoke about the nursing shortage, and I mean, in terms of people who may be headed to nursing school or maybe thinking about nursing as a career, like now is the time, right? Like I found this number of over 190,000 openings for nurses through 2032, some related to patient needs, some related to burnout and people leaving the field, some related to people aging out of the field. But we have opportunity to help people move into the nursing profession. And certainly we want people to come because they see us enjoying what we do. And we talk about this a lot in leadership meetings in the department is when people come and interview, are they talking to people who are happy where they're working and happy in their jobs, content? I mean, nothing's perfect. Nursing wellness. So just like in the physician world, in the nursing and the nursing oncology world, these are a couple of links where you can see if this fits with you. So I talked about this idea that you go to the self-help session or go to a section of the bookstore, or you go to Psychology Today, or you decide you want to do some coaching or some wellness activity. What is going to resonate with you? And sometimes you can be motivated because other nurses are motivated. Like maybe you motivate each other. And like that's a space where you listen to whoever is promoting the healthy diet. And there's one, right? Like it's the Mediterranean anti-inflammatory diet, right? Like it's like no secret. But if whatever they're doing resonates with you, then that's the program for you. I just wanted to speak briefly about patient distress because of being a psychiatrist in a cancer center and maybe thinking like it's not a half bad idea for us all to fill it out one time or another. And this is the distress thermometer. It's what the National Comprehensive Cancer Network suggests that we do for new patients and in follow-up to see how they're doing. Maybe you fill it out yourself, right? How am I doing from all these like physical, emotional, and social parameters? Or you could do a different kind of self-screen, take 5, take 10. We're actually in a pretty place, like take a walk at lunch, the answer to all burnout at lunch, and examine like what's going on with me? Like what am I like ruminating on? What kind of mood did I bring to the conference today? Like what am I seriously going to sit here and scroll on Instagram some more? Am I going to get up and go move around? There are many scales, instruments that help us measure not only burnout, but resilience, depression, the PHQ-9, anxiety, the GAD-7, and then I mentioned the distress thermometer. It won't just happen. It won't just come to you. And part of the role for psychotherapy is allowing the time and space so that you can really think about what's going on with you. It just doesn't pop in while you got the radio on and you're driving, you're trying not to get run over by the pickup truck that's going 75 miles an hour down the road. Like it really has to be protected time and space for you to reflect. How are you talking to yourself? So you can imagine the difference in your emotions depending on how you're talking to yourself. So I sort of went down the list, right? And your emotional reaction, depending on the narrative you are saying in your own head, is profoundly different depending on what you're talking about. Then you got to know your resources. So depending on where you work and who you work with, HR is not just hiring and firing. There's some really good people with some really good kind of life skills, like work-life balance. People tend to go into HR because they're interested in people. At Emory, we have a mental health resource hub that's put together by our MWell colleagues. If you decide to talk about something that's bothering you from an emotional perspective, I wrote trusted colleague. We are still in the work environment, right? We're in the professional setting, and we want to think about what's going on with me that I'm able to safely share with this person? What's going on with me that I need a separate space, a little distance, a little bit removed from my day-to-day work environment? A supportive friend or family member, and you got to watch out for the label. What do I mean by the label? This is my partner. He should care and listen to me. This is my mother. She should want me to be happy. This is my daughter. She's 30 years old. She should be able. It's got to be the person that kind of gets it, right? It may not be the label of partner, mother, brother, boss, It may need to be somebody else. And that's where we have to take the time to figure out who gets it. And, we say that to patients all the time when we ask them to go to a support group, that these will be the people that get it. And we tell them to go because they'll get it. And sometimes it works and sometimes it's a bad group. Or sometimes somebody just died in the group. I mean, all kinds of things happen. It may need to be a different person for different circumstances, but watch out for the label. That's a good reminder. Okay, and then professional support. We talked about therapy. Let cancer be our motivator. We all know about it. We all live with it. We all see it day to day. Some of us have been through cancer treatment and are survivors ourselves. Like, how can I reduce my cancer risk? And is that good for my overall well-being? Like, maybe I can get motivated because of literally the work I do. And then sharing carefully. That's about social media and whether you decide to share some of your wellness journey, your medical journey, your family journey on social media. It's out there forever. And so you just got to make sure that that's something that you don't mind having public for a long period of time. But it can be a great motivator. I mean, the American Cancer Society, National Cancer Institute, Livestrong, if they're on your feed and they're popping up in your head, you're consuming potentially healthy messages, right? If all that's on your feed is a bunch of Hollywood gossip or political back and forth, that's what you're consuming. That's what's in your head. So we got to think about what are we consuming visually, audiology? What are we hearing? Gosh. Okay. And of course the Winship 5K is coming up. Oh my God, you're cheering. I love it. Okay, here's why I love the 5K. Because people come with their families. People come with these t-shirts that they make or their friends make. People come and they're energetic in the morning if they're volunteering or cheering. People come and just hang out. People come and walk. People come and run. Some come and run like the wind and it's but whatever, they run fast. That's great. So, but they do all kinds of things. And it's just coming together to say, really, cancer sucks. And our patients and families going through it, it really is awful. But in this moment, we can do something about it. In this moment, we can get out and do all these healthy behaviors that are good for our wellness and hopefully raise money and cure cancer. But, it's long-term goals. Okay, integrative therapies. People want to ask about this a lot in wellness. And we have a naturopathic physician now at Winship, and we have a survivorship and integrative care program run by Dr. Masters in urology. And so these things are of interest to patients, of interest to people, have some data, like with acupuncture and chronic pain and maybe in nausea. These stress reduction practices through the ages, things like Tai Chi. Does it say Tai Chi? Tai Chi have opportunity to treat things like fibromyalgia, which is essentially fatigue and chronic pain. So we have a real opportunity to implement some things, maybe some opportunity to also talk about caution. Where are you spending your money? What are you putting in your body? Really, what is in that supplement? Maybe we have an opportunity to talk about trusted brands and to look at other kinds of therapies. And people go and get master's degrees in art and music therapy. And it can be an intervention sometimes covered by insurance, depending on what it's married with, but often something people can invest in that really very much improves their sense of well-being. And then at the end of the day, you got to think about what are you going to do? What's going to work for you? So this is what works for me. So that's Molly, who's my pandemic puppy. And it was kind of a leap and kind of a mess at times, but also just a complete joy. Like, she is just energetic and cuddly, and all the extra stuff I have to do is worth it because of the good energy she brings. That works for me. It doesn't work for everybody. I have friends with dog phobia and allergies, and dogs are expensive. But I found something that worked for me. And also, I like flowers. And so I take pictures of flowers and I cut flowers. And every once in a while, like on a birthday, I'll buy the flowers. So that's what works for me. And your homework is to go home and figure out what works for you, because that really is what matters. In terms of being resilient, which sometimes can be an overused word, kind of like safety, but it's an important word. It's a word that we can really strive towards. And the other one would be post-traumatic growth. So depending on what you go through, depending on what our patients and families go through, sort of the highest order is to experience what we call post-traumatic growth. And that can be a talk for another day. Thank you guys for listening. Any questions?